If you guys type any questions, because I don't know that I'll see it, but I want you to ask questions.
So Meggie, we were talking about at the last meeting, like our students have the opportunity to do this like online telehealth course to learn more about it, because we were talking about how, you know, there are a lot of people, jobs are kind of in high demand at the moment because of the current situation, and how some of our colleagues got furloughed. But I was encouraged to see on the group me that there were like a ton of patients at APPENDICITIS.
Yes.
Oh, were you at APPENDICITIS yesterday?
I wasn't. I was at Winter Garden, but it was busy too. Both have been picking up so much.
So that's great.
Yeah. I think our hours are just all going to go back to normal now, I hope, because we've been staying like 2 hours after our shift without the extended hours, so.
Yeah, that's good.
You guys are back rotating pretty normally, or?
Yep, they're back. Trying to get all their surgery and ER stuff, because those are the ones that opened up the most recent. So they're trying to get all their stuff in so they can all graduate on time. And so far it looks good.
That's so exciting. It's so soon.
I know.
I remember being there, ready to be done. So close.
Yeah, so I wasn't teaching yet when Meggie went through because you graduated from us, right?
Yeah.
Mm-hmm. So I wasn't here yet teaching, but I was working for Team Health, and then she went into the residency program. And so I met her when she was kind of paired up with me for a month or a couple months or whatever.
Yep, I learned from Stacy during the residency.
So, but she was great, awesome, super energetic. We had a lot of fun.
We did. We did. Winter Garden's the best place to work for sure. So yes, we love it there.
But she is, you know, of all the, I've been with that group for a pretty long time. And, you know, all the physicians and my colleagues there really hold her in high regard. So you guys are lucky to have a lecture from her tonight.
Yeah, and just bear with me. I haven't done this yet, so just ask me questions. I tried to make it more based on some board stuff after the first few slides, so hopefully it helps, because it's hard for me to remember what you guys need for your boards at this point.
So I think we're good. Maybe if you want to start and if people want to join in, just so we have enough time at least to finish.
That's fine. I don't think it will be 2 hours either. I'm not sure.
Okay.
But yeah, basically the floor is yours. Once you're done with them, they are good to go. So, all right. So,
all right.
All right. So if everybody, if you would please give her your undivided attention, I will stop interrupting.
Thanks, Robbie. Yeah, and guys, please just ask me questions as we go along. Like I said, I haven't done this, and this is definitely the first Zoom one, so please, I will stop at any point. And the first few cases are nothing that you will need from your boards. I just thought they were kind of interesting recent cases that I've had in the ER with everything going on in the world. So I find them interesting, and I hope you guys too, but they're not really so much for your board, so I apologize. So yeah, case one that I had recently, we've been having obviously a ton of patients come in with the pandemic going on. And this was a 38-year-old guy, no health problems. He came into the ER. His chief complaint was fever and body aches for 3 days. He had had like low-grade fevers, been taking Tylenol for them, and that would bring his temperature down. But his biggest thing that he said was he had this 6-month-old baby, and he said, I'm so weak, I can barely pick up my baby. And he was like a really young, athletic looking guy, and that just seemed kind of strange to me. But he had no other symptoms, no cough, no shortness of breath, no chest pain, abdominal pain, no other complaints. When he was in the ED, he did have like a low grade temperature, and he had taken 1 gram of Tylenol before coming. So that tells us, you know, his temperature was probably higher than that because he did the right thing by taking the Tylenol to bring it down. Other than that, his vital signs were pretty stable, a little bit tachycardic, but that correlated well with his low grade fever. No medical history with him at all. And the pertinent things on his physical exam were he seemed a little dry, he seemed dehydrated, he was a bit tachycardic, but his lungs were clear, and I never heard him cough when we were in the room. No shortness of breath. He was speaking to me in full sentences, no distress. So on this guy, you know, the main reason why I decided to get some labs was just because, you know, I could tell something was going on because he said he can't even care for his own baby. He couldn't pick her up. So these were his labs in the ED. So here we have a CBC. So that's kind of the CBC and BMP are pretty going to be basic on like all of these cases that we do. Those are 2 labs that we always order. This one is actually a CMP though, because the difference between BMP and CMP is that the CMP has these right here: bilirubin, ALK-Phos, ALT, and AST. And then on him, I added a CK level because of the way he was saying his body aches and his weakness. So that's a big thing on him, and that's something that we do a lot in the ED if they're complaining that it seems like dehydration or something of that sort. So anyway, I was not expecting this, but his CK was 49,000. Normal is like less than 200, so it should not be this high, and I really wasn't sure why it was that high. But this is someone who we wanted to admit to the hospital for IV fluids and to find out why is his CK so high. And it turned out that he actually had COVID. So he had like no symptoms that you hear about, you know, on the news and everything with this, but he did have COVID, and they found that out on admission, which I wasn't expecting that either. So when he was admitted to the hospital, I don't know if you guys can see this, but the biggest thing that I wanted to put these slides up for you was because his CK level in the hospital every single day, it just continued to rise. And that was just so strange because it is something they're tracking with COVID lately, but on him, I just kept following him because I was interested, and his CK level got up to all the way up to almost 200,000 while he was in the hospital, and they just kept giving him fluids, and essentially they waited for it to kind of come back down before they decided to send him home. And another interesting part of this is just with COVID, another thing that they're trending is the D-dimer test. So I found that kind of interesting that his was so high. And that's kind of just like an inflammatory marker. But yeah, so it was just kind of strange because this is a young, healthy guy, and you can see that COVID is just doing very strange things to everyone. So this was just kind of, I think I already said all this, but this was his outcome. When he was admitted, they just continued to give him IV fluids, and each day the hospital notes would say, you know, waiting for his CK to come down, and it just kept going up. So I think everyone in the hospital was kind of shocked. They had a lot of specialists involved, but the whole time his chest x-rays remained normal. He never had shortness of breath. He never had cough. His only symptom was really just like the fatigue, dehydration, and body aches. So essentially, I think he was in the hospital for, let's see here, it was about a week, and they didn't send him home until he had 2 negative tests, and he's doing fine now. I like to sometimes track my patients and call them and see how they're doing, and he's doing fine. But I just thought that that was kind of an interesting case with COVID. So if you have body aches, then be careful. Any questions about that one? Okay. And again, this is just another one that's not related to your board, so I'm sorry.
There's a question in the chat.
Yeah, I see. Okay. No, he didn't. He was not a smoker. He did not, I think he said he drank socially. Good question with the AST and ALT. Yeah. No, that's just another thing that they're seeing in these COVID patients, that they're seeing their hepatic enzymes be elevated. So as far as I know, he did not have a history. He did not admit that to me, but he didn't seem like it. So yeah, I think that that was just something that has been elevated with COVID. Good question. Okay, so the second case is another one. So the 62-year-old guy came to the ER. He did have cough for 5 days, fever, and his main reason for coming in was because he was just extremely short of breath. He said that anytime he would get up and even walk a few steps, he felt like he was he could barely breathe. He's having high temperatures, up to 103, and he was taking medicine. He complained of chest pain, but it was mainly, you know, from his coughing. But no other symptoms, no abdominal pain, nausea, vomiting, diarrhea, headaches, neck pain. He had said he had no sick contacts. I remember this patient specifically, he actually said that his wife had just died about a month prior, not anything related to his illness, but that he really was keeping to himself. He was only going to the grocery store. It wasn't like he was out working or really being around people too much. So he didn't think he was exposed to COVID. But with his symptoms in our ER, he was in our COVID section. So, you know, we were kind of thinking this on this patient, but rather than we weren't on the other one. But with his symptoms, we were kind of thinking it in the back of our mind. So anyway, his medical history, he did have some health problems, kind of standard for his age though, 62. He had high blood pressure, diabetes, high cholesterol, surgeries, just past hernia repair, appendectomy, no heart or lung surgeries is the big thing on him. And so on his exam, you know, when I was talking to him, he wasn't complaining necessarily of shortness of breath unless he would get up and walk. But while I was talking to him, I could tell every few words, he would be kind of short of breath. So I did notice that on his exam. His lungs, there was no wheezing, but he was diminished on both sides. And I could tell he wasn't really taking that full deep breath. And then his heart, he was a bit tachycardic, but I don't know if I put it, but he had had a fever when he came in, so it was like 103. So I expected him to be a little bit tachycardic. This was his x-ray in the ER. So when we look at this x-ray, you know, we see lots of bilateral infiltrates. He has scattered congestion on both sides. This is a one view x-ray, so it might look worse than it, you know, actually was, because a lot of times the one view, it's a little bit harder to see, and he was a bigger guy, but you can definitely tell all this right here, lots of vascular congestion. So to me, it looks more like viral pneumonia, something's going on. We know that that's an abnormal x-ray. But these were his labs in the ER. And so his CBC, pretty unremarkable. These, nothing too remarkable about them. The big thing, his white blood cell count was normal. This is his chemistry. And again, whoever asked that question before, see his enzymes were also elevated. So this is kind of a trend that we're seeing right now with COVID, that it's affecting the liver. But yeah, so his were a bit elevated. He also did not have any history of alcoholism. But, you know, overall, I thought his labs were a little bit unremarkable. His sugar was high, but, you know, he had a history of diabetes. He took metformin, so not crazy high, but high. And so again, I did test him for COVID, but our tests do not come back right away in the ER. So I admitted him, of course, just from that x-ray and how he was presenting. And then a few days later, we found out that he did have COVID. And so this guy was a sick one. He was sick. So this next slide, this is his x-rays. He had a lot more, but I just chose these because I thought we could kind of look at the difference. But so this was when I saw him in the ER. That's the x-ray you already saw. And so you can see that. And then that day when he got admitted, like I said, they've been trending the D-dimers, and his D-dimer was 1.1 that day. This was a couple days later, 517, after some treatment. So really they're treating these with, you know, steroids, and sometimes they're trying some antivirals or antibiotics, but his x-ray still looking pretty rough. These look almost more patchy now, the bilateral infiltrates. This is 521, and if you can see the difference on this x-ray is that he has a tube down his throat. So at this point, he was intubated because he got a lot sicker. So it happened pretty rapidly overnight. I was following his case, and they were almost ready to discharge him on the 18th after this x-ray here. And then the 18th night, he just really went downhill. He was in respiratory distress. His O2 sats were like in the 60s. And so this is his x-ray from the 21st when he got intubated, which was really sad for me to see because when I was following him, I thought he had been doing a lot better, but he went downhill. At this point, the day he was intubated, his D-dimer was 3. So it's just kind of interesting to me how it correlates, how everything got bad, bad, bad. And then you can see here, he was discharged on this day, the 3rd, and no more tube in his throat. His x-ray looks a lot improved. It's still not great. And his D-dimer had trended down at that time. So just interesting, COVID. So yeah, this was basically his outcome. He, like I said, he was admitted from the 11th to the 4th. It was a really long time, poor guy. He was on the ventilator from about a week, and then he was discharged the 4th, and he has been doing well. I talked to him that week he was discharged, and he had been feeling a lot better. So we're lucky that he's still with us because there was a couple days there where they thought he wasn't going to make it, but he was just fine. So those are my 2 COVID cases, and both are okay outcomes. They both did okay, so we can survive COVID. Any questions about that one?
I have a question for you.
Yes.
At what point, from an inpatient side, so the D-dimer's climbing, now they have to intubate him, he's clearly having respiratory issues. I wonder at any point in time, did they have a discussion about doing a CTA on him? Like, what if this is a PE? I mean, there's all that information going on and all that. It's like, I wonder if they just kind of are like, oh, it's COVID, forget it. It's definitely not a PE. I mean, I didn't know when you were doing the chart if they said anything about it. Did they?
No, they haven't, and they have been trending these D-dimers on every patient, and I agree with you. I think it's very interesting because I've been reluctant to even order the D-dimer in the ED because on these it's pretty, this guy was clearly like COVID pneumonia to me, so I didn't order the D-dimer. And now they're ordering the D-dimer, but they're not doing the CTA. And for all of you students, that's something like in the ER, if you order the D-dimer and it's positive, you're doing the CTA. You're not just, admitting them or sending them home, you're doing it. So that's definitely a learning curve right now for me because I've had a couple patients where they want the D-dimer now to be admitted, but they don't necessarily need the CTA. So it's interesting. But I think, Stacey, they're doing it like case by case because then I've had a couple younger people who I admitted for COVID, and I saw that they did do the CTA on them once they were in the hospital. So I don't know what their guidelines are for following it. It's interesting.
Right. Nick, that was kind of my question, exactly what you were saying. They're looking for a DVT. They could do bilateral ultrasounds quickly just to kind of see and look if we need to go down that road. I mean, it seems pretty typical. No, that's okay. But I think those are good things, and it's kind of one of those like judgment calls. You really got to look at the history of the presentation and what's going on, and I think that gets to be kind of a risky situation. As a provider, I think, well, God, like I hope they don't. They end up dying, and an autopsy there's a cell pulmonary embolus.
Exactly.
Or whatever, and they're like, oh my God, what did I do?
Yeah. What did I miss?
There's an elevated D-dimer. I mean, how's that ever going to stand up in court, So
yeah, I think they are doing it on some people, but I mean, the benefit I think from the CTA anyway is it shows the multifocal pneumonia a little better too. So you can't. I feel like they should just kind of be doing it, but it's case by case. So it's interesting how they're looking at that.
If you want to hit your slideshow view, it might help make those slides bigger for the students.
Oh, shoot.
At the bottom right on your PowerPoint, if it looks like a little slideshow, it's like the 4th icon over.
Oh, there we go. Did you see it?
Yeah, and then you get rid of the little ones, and maybe they can see those lab values.
Okay. Yeah, I didn't even know. Sorry, guys.
Yeah, no.
Okay.
That's good. Good.
Okay.
All right, carry on. Thanks.
Okay, so case 3. So this is more gonna gear towards your guys' stuff that you will need to know. So ask me any questions. 17-year-old female, she presents to the ED with periumbilical pain for about a day. It began to radiate to her right lower quadrant. It was periumbilical before. She's been nauseous, but has had no vomiting, and mother does report she's had a fever. Taken IV, that's supposed to say she has taken ibuprofen for the pain with little relief. Vital signs, low grade temperature, heart rate's 99. Otherwise unremarkable. So her health history, no medications, up to date on vaccines, healthy 17-year-old. Big question on this patient is you want to ask last menstrual period. So it was 1 week ago. Past medical history, no previous surgeries. And on her exam, she was tender to the right lower quadrant with some guarding. And so what are some signs that we should check for with this patient that will be on your boards? Good, Rob, someone said that. So yeah, Rob Singh, there's a couple others. SOAS, yep. Op trader, perfect. Yep, all of those. Okay. So with her, we did labs. She had an increased white blood cell count, increased CRP. Is there any other tests that we should order on this patient as far as labs? So another one, usually, exactly, yes. So perfect, that's kind of what I was looking for, is a pregnancy test. She is a 17-year-old female, so we definitely want to get that pregnancy test because we can't really go any further in our workup until we know, is this patient pregnant or is this patient not pregnant? So that is awesome, good answer. So her pregnancy test was negative, so that allowed us to then, I did order a CT on this patient. You know, she's 17, she was a bigger 17-year-old girl. And so we don't always jump straight to CT. Sometimes on more pediatric patients, you would want to start with ultrasound, look for the appendix. And, you know, ultrasounds can help a lot if they can see the appendix. If they can't, you know, it's one of those, do we need to do the CT now? Are they feeling better? But this patient, I had a gut feeling of this diagnosis on her, so I just went ahead with the CT. I discussed it with the mom and said risk benefits of CT, and the mom had agreed, so that's why I did the CT. But always try to do ultrasound first on pediatric cases if you can, just to save them the radiation. So this was her CT scan. Oops. So here you can see some enlargement, and then you guys are over this picture for me, but I think it's like right here. You can see this is just the very distal colon, and it's an enlarged appendix. So those are just some findings that we saw. This patient was obviously admitted. Anytime there's an enlarged appendix, admit the patient. We call general surgery right away. They usually will help you with what antibiotics they want. Lately, I've been finding that they want Zosyn, which is kind of like a broad spectrum antibiotic. You keep the patient in PO, and nowadays, these appendix surgeries, usually the day I admit them, that appendix comes out and they go home the next day. So it's pretty quick. So these are, I tried to, each case, I kind of did a slide with some board pearls. It's pretty just straightforward, to the point stuff. So it's definitely not in detail, but I figured you guys might be able to just look over this quickly when you're studying, and just some keywords that, you know, board words. So appendicitis, the most common reason for urgent abdominal surgery. The peak is teens to 20s, but I mean, it can be any age. I have seen it on 80-year-olds, you know, any age. These people, you got to think appendicitis, obviously, with belly pain. The classic thing that the boards will say is that it starts in the epigastrium, moves periumbilicus, and then to the right lower quadrant. But I will tell you, from a clinical standpoint, that is not always the case at all. You know, these people can present so many different ways, but for your board's sake, I think that that's more likely the question that you'll have is periumbilical pain radiating to right lower quadrant. And then, like you guys answered wonderfully before, these are the signs, and I would definitely know those for your boards because they might describe it rather than say Rob Singh. And they may want you to kind of know that. So robsing is when you're palpating in their left lower quadrant, but they elicit pain in their right. Psoas is just when they're laying there and they have their thigh extended and they say, oh, it hurts in my belly. So that's like kind of when you raise the kid's leg up and says, does this hurt? Obturator is when they're flexed and you kind of internally rotate their leg and they're complaining of that right lower quadrant pain. So I would definitely remember these and remember the difference, because they may word it differently on the boards to where it's not just this key word, but rather, you know, how they describe it. And something in the ER standpoint, one thing I always do is in a pediatric patient, we have them jump up and down. So that kind of covers all these signs in one, but that's something that, you know, I always put in my chart. Patient can jump up and down without difficulty. And that's not really boards, but clinical wise, that's a good way to just kind of test all of these. Can the patient jump, you know, little 4-year-old, can they jump up and down? Yes, that's a good sign that it may not be appendicitis. And then with this, the test of choice would be a CT scan with contrast. And then of course the patient goes to surgery. Any questions on that one? Appendicitis, that will definitely be on your boards. So I feel like you guys are pretty good at that though. The students I've had, you guys always think of that. So any questions? Okay. All right. Let's see. Moving on. So this is a 55-year-old female. She presented to the ER, left lower quadrant abdominal pain. It's been going on for the past 3 days. She told me that at first it was kind of just a dull pain and would kind of get better on its own. But the day she came in, it was just a constant pain, really nagging, mostly in her left lower quadrant. She had said she had some loose stools the past couple of days. She didn't really describe it as diarrhea, just loose stools, and she did see a little bit of blood in her stool. So the patient says that, yeah, she's had this in the past, but it just went away on its own. She didn't have to do anything about it. Her vital signs were normal. So no, up to date on vaccines, no allergies. She had a history of high blood pressure and acid reflux. She did drink socially, but was a non-smoker. And on her exam, she had generalized tenderness, seemed to be worse in her left lower quadrant, but kind of with a little bit of guarding everywhere. So what other tests not necessarily exam, but what other tests? So what labs, should we do a scan? What should we do next with this patient? Any thoughts? Nicole, perfect, that's a good idea. Yep. Because she had blood in the stool. And then how about lab wise? What are we kind of looking for in labs? CMP, CBC, perfect. Awesome. Coags, great idea. CT with PO, yeah. So you guys got it. Basically all of that. In the ER, we really don't do CTs with PO contrast much. So I can't remember what your boards would say for this. They might tell you PO contrast, but honestly, it's not a test I order too much. And I really forgot what they teach you, but definitely a CT with some sort of contrast is what you need for this. So her labs, sorry, I didn't bring all the labs in on these cases. These are all real cases, but it took forever to copy and paste them on my slides, so sorry. So she did have an increased white blood cell count, and then her CT I did IV contrast, acute diverticulitis in the sigmoid colon. So the treatment for her was ciproflagyl, or like I said, Zosyn is kind of one that we're doing more often in the clinical setting. I think on your boards, it will be ciproflagyl is kind of the go-to for this, but in real life, we're trying some different antibiotics. So with diverticulitis, let's talk about it, because there's kind of like different things that we look for from an ER standpoint. So this patient particularly, she had uncomplicated diverticulitis. She had no perforation or abscess. So that's what we see on this CT scan right here. You can just see this thickened sigmoid colon, but you don't see any perforation or abscess. So that was kind of where she was. But then the complications of diverticulitis that we always want to remember are, is it perforated and is there an abscess? So this CT is showing a perforation. You can see these little micro perforations where it's darker. And if it says perforation, you're calling surgery. You know, sometimes it won't require surgery and the surgeon will just kind of watch it if they're micro perforations, but any perforation, admit the patient. And then of course, abscess, admission, these are the patients that usually present a little bit sicker and they're usually febrile, they look sick. And as you can see this CT here, this is a big old abscess. So the diverticulitis just got so bad that it formed an abscess there. So from an ER standpoint, it kind of depends on all of these things, whether we admit the patient or we don't. You know, if it's uncomplicated, they're less than 60 years old, they're not immunocompromised, if they're pains controlled, they're eating, they're drinking in the room, you know, usually you can send these patients home with PO antibiotics. I always tell them, come back in a 24-hour recheck, you know, so we can reassess, do a belly exam. But if there's ever perforation or an abscess, admission, IV antibiotics, consult surgery. But it just kind of depends on the patient, because I also have admitted patients before where it said uncomplicated, but you know, they looked a little sicker to me. They really didn't want to eat or drink. So I wasn't comfortable sending them home. So that's just kind of, you know, it takes time to learn which ones you're comfortable with, but this is just a little bit of info on that. So board things for diverticulitis. So we have diverticulosis and diverticulitis. Osis just basically is when it's a little bit inflamed, and that's the most common in the sigmoid colon. A lot of people can have diverticulosis. That does not really mean much of anything. It's not infected at that point. These patients, you know, their risk factors, if they're a little bit older, greater than 60, they have a high fat diet, low fiber, and you know, they will most likely eventually get to the point of diverticulitis. So on these people, if you see that on their scans, then, you know, educate them on what kind of diet, what they can do to change their lifestyle so that they don't, you know, progress to diverticulitis. And then diverticulitis, of course, what we just talked about, obstruction of the diverticulum. So there's an infection in there. They usually present with left lower quadrant pain. That will probably be your boards, you know, some blood in the stool, nauseous, vomiting, fevers. And like I said, flagell, metronidazole, that's the same thing as flagell. Cipro is usually the treatment of choice on your boards, and the complications, abscess and perforation. Any questions on diverticulitis? I hope that kind of all made sense, but that's a pretty common one that you'll definitely see. Do you check renal function every patient? Yes, so absolutely, yeah. At the ER I work in, like we usually do BMP, like point of cares. If you know you're gonna have, if a patient presents with bad abdominal pain and we know they're gonna scan them, you can kind of do a point of care test to where it's quick and they get a quick creatinine BUN, and then they can take them to CT safely. So yeah, definitely. And patient before giving IV contrast, even yes, yeah. So even the 17-year-old, every patient you would check for BUN and creatinine. And really CT scans are so good nowadays that you can see a lot without contrast scans. So it's usually not an issue, but yeah, you definitely don't. And if it's kind of a little elevated creatinine, sometimes the radiologist tech will say load them up with fluids before and they'll be okay. But I usually don't risk it. I usually just order it without if they're elevated. Yes, exactly. The cost of the test is not worth the kidney. Yeah. You need those kidneys, but you can live with one. So, but you don't want to do that to your patient. That will be a lawsuit. Okay. Any other questions on that case? All right. So this one, 42-year-old male presents to the emergency room with right flank pain. It radiates to his abdomen, groin. He said yesterday it was dull, but today it's severe, it's sharp. He was in distress, definitely not comfortable. He had nausea, vomiting, and felt feverish. He had a little bit of dysuria, but no blood in the urine as far as he had seen. Vitals, lowish grade temp, you know, little leaning towards tachycardic. His blood pressure was high, but my guess with that was because he was definitely in pain. He was in distress when I saw him. He does drink alcohol daily. He said about 2 to 3 beers a day, which, you know, that you always double what they say. And medical history of high blood pressure, but not diabetic, nothing else. And then his exam, moderate distress. He was actually standing at the bedside, you know, holding his flank. He didn't want to sit in the bed, kind of restless, anxious, just definitely uncomfortable. And on his exam, right CVA tenderness with right lower quadrant tenderness and some guarding. So what are some differentials? I feel like as soon as I change the slide, we already know the answer. So what are we thinking on this patient? Yay. These are obvious, aren't they, guys? Okay, so yes, we're thinking kidney stone, definitely. So his labs, he had leukocytosis, so his white count was 17, his creatinine was elevated, 2.5, and his urine, he had some white blood cells, he had some red blood cells, definitely showed an infection. So what kind of scan do we want to order on this guy? Yes, perfect. Good job, Kyle. David. So yeah, CT with non-contrast. Most all other things I feel like in the ER, it's with IV contrast, but with him, non-contrast CT for kidney stone. Good job. So this was his CT, and you can see this bright dot. That's about the only time I can see anything on scans is when it's a bright dot kidney stone. So his was 6 millimeters. It's at the UVJ in his left kidney. So with these, it kind of depends where it is, how big the stone is, and a couple other things. So we'll talk about that, I think, on the next slide. Yeah. So kidney stones. This is from the ER perspective. I don't know about every other specialty, but stones, if they're less than 5 millimeters, they usually pass on their own. The patient can go home. You give them urology to follow up with. It's usually no big deal. I mean, it is for the patient. It hurts like heck, but from our standpoint, less than 5 passes on its own. When they're 5 to 7, it's kind of that gray area. So you always want to call urology, especially if they don't have a urologist to follow up with, and say, hey, I got this guy. It's his first time having a stone. I just wanted him to be able to follow up with you, as long as the patient's comfortable going home. And then if it's greater than 7, they got to go to surgery. It's usually lithotripsy, where they kind of break up that stone and you admit them. So again, the disposition really depends on where the stone is, and is there multiple stones? Is there infection in the urine? And what is his creatinine? So it depends on all these things on what you're going to do with the patient. So this patient, for example, his stone was 6 millimeters. He did have leukocytosis and his urine was infected. So he got admitted because all of those things together are not a good combo. We don't know if it's going to pass on its own. We saw it's already affecting his kidney function and it's causing an infection in his urine. So he's not a safe one to send home. So it depends on those things. So size isn't always the factor, because you can have someone with a stone that's less than 5 millimeters, but their creatinine's elevated and their white blood cell, their urine has infection. So even those you would admit if it's affecting those 2 other things. And then of course, does the scan show hydronephrosis? Again, that's not always a determinant if you're gonna send them home or not, but usually that's a sign that, yeah, this person's struggling, their kidney's struggling, and you wanna admit them so that they can get IV fluids, IV antibiotics, and a urology consult. So yeah, that's kind of what I said down here. It really depends on the patient and the size of the stone and all of that. So yeah, it just depends on those things, whether you're going to admit them or not. All right. What questions do we have on the kidney stone case? And I know there's stuff on what types of stones there are. That's not something, I cover too much in the ER, but I did write down a few things for you guys because I think that probably might be on your boards. So the most common stone would be the calcium oxalate stone. And that's more people who do like tea, caffeine, chocolate, nuts, potatoes, that kind of diet. You'll see that kind of stone. And I read that that was the most common one. We don't ever know what type of stone it is in the ER. We just, see the scan in the labs. And then another thing to know, I would say, is that the uric acid stone is more the people that eat a high protein diet and they're dehydrated. So you could probably see that more like in your younger patients. And that's just something that I tried to look up for you guys, because I remember having to know the stones, and I honestly now don't know too much about it. So any questions on that? All right, moving on. 78-year-old female presents to the ER with acute abdominal pain this morning. It's pretty severe pain. She has history of atrial fibrillation, and she takes Eliquis, associated nausea and vomiting. Her son brought her to the ER and said, "My mom is a tough lady. She never usually complains of pain. I'm really concerned about what's going on with her." Her vitals looked okay. She's a smoker, 20-year smoker, no other history other than AFib and hypertension. That's what she took the Eliquis for. Moderate distress on exam, diffuse abdominal tenderness. So what are our differentials on this one, and what labs? Awesome, you guys are smart. Okay. So yeah, mesenteric ischemia is what we're thinking. So if you get a board question, older person with AFib, that's probably going to be some sort of in your answer. Definitely differential. So what labs and tests should we order? It's kind of similar to other things, but you guys probably know it. Yep, perfect. Good job, Kyle. CBC, CMP, CT without contrast, EKG, lactic. Perfect. Yeah, and lactic is not too, it's sensitive, it's not specific to it. It can be elevated. That doesn't necessarily mean it, but it's a good one to order on these patients, especially if you have a high suspicion. So her labs were actually within normal limits, which was kind of strange, and that can kind of throw you off, because then you're like, is this patient just, is her pain out of proportion? What's going on? Why is it like that? But her CT abdomen with IV contrast showed bowel wall thickening with a vascular embolism, and she had some portal vein gas. So portal vein gas, I think, is, kind of keyword. But the labs I would have ordered on her, I'm not sure if I put them in here, but the basic labs, you get the PT INR on this patient because she's on a blood thinner, so you're going to want to look at that, and the lactic. So this is kind of covering board as far as mesenteric ischemia. So there's a couple different types: embolic versus thrombotic or non-inclusive. So embolic is the most common one that you'll hear about on the boards, and it's the superior mesenteric artery that is compromised blood flow. So that's why they're in this severe pain, because their blood flow is cut off at the superior mesenteric artery, and their pain is out of proportion to their exam. And like I said, her labs were normal, so it's just out of proportion. You're like, what is going on with this patient? Her labs look okay. I don't know what's going on with her. You got to think this diagnosis. So yeah, I mean, to be honest, in the ER, we do CT with IV contrast. When I was in PA school, I remember they would always say mesenteric angiograph for the boards. I don't know what you guys have learned, but I have never ordered this in the ER, but that might be what they ask you on your exam, Stacy. I don't know if that's something you would know, but I remember learning mesenteric angiogram, and I've never ordered that in my life. So.
No, and I think from an ER perspective, no, but there's always on the boards, right? There's going to be those gold standards that you.
Yeah, I think that's the gold standard. Yeah.
Right. So we're going to do things that are maybe faster, quicker, accessible to us, and whatever. So when you study for the boards and those board review books, always look for those tests, because you think you might think because this is what you did on your rotations, but that's not the correct answer. Make sure you pay attention. Gold standard, and what is it?
So again, this is elderly patients with this intractable abdominal pain out of proportion. Their risks of AFib, they usually have history of AFib, CHF, or some blood clotting disorder. So those are the keywords to look for your boards. Questions? All right. 32-year-old homeless man presents with back pain for a week. He had worsening pain for 2 days. He had fever, vomiting, and diarrhea. He told me that the night prior he had this episode of urinary incontinence, but he hadn't had it since then, so it wasn't like it was just a one time. But he came into the ER today because he was just having difficulty even getting up and walking. And I will say with this patient, he's a frequent flyer back painer in the ED. So a lot of people, you know, they kind of blow him off when he comes in. And it's hard, you know, because when you look up the patient's chart, you see, you know, this is his 10th visit in 1 month. He wants pain medicines and he wants food and a place to stay because he's homeless. And I had seen him multiple times prior, but this particular day, I wanted to bring this case up because it was kind of crazy. So yeah, so he was a frequent flyer and just this back pain. So when I saw him, he had a low grade temp. He was tachycardic, but it's so hot outside and he's homeless. So, you know, I wasn't sure if it was related to that. He was really, you know, unkept. He looked sick. But he told me he wanted food and a place to sit. So I didn't think much at first, but then as I started examining him, I realized something was going on. So he, like I said, he was homeless. He is an IV drug user. He told me he had used heroin 1 day prior. So on his exam, he would refuse to get up and walk for me. He had come in from a wheelchair or ambulance, sorry. He had called EMS from the street. And so his neuro exam, his left lower extremity, his strength seemed a little bit weaker. It's hard to honestly get that on exam, but it did seem weaker to me. But he had good reflexes, and I checked the straight leg raise, and it was normal. His sensation was normal. His rectal, though, so we always do a rectal on these patients if you're worried about something going on with their spine, and he did have decreased tone. So I knew something was kind of strange about it. So what other tests do we want to order on him? CRP, good. Lactic, good. Yep. Yep. Perfect. Yep, you guys got it. So, and from the ER, it's very rare we order MRIs. I mean, I have probably only ordered 4 MRIs in 5 years of working. So, it's pretty rare. You have to have a really high suspicion that something's going on to order it. We usually start with CT, but obviously on this patient, if we're thinking epidural abscess, we got to order that MRI. So yeah, these were his labs. So, you know, nothing actually too crazy on it. His white count was 10. That's not too out of proportion. His CRP was a little elevated. His lactic was normal. Another thing is we would always order blood cultures on this type of patient because we know we want to start him on IV antibiotics right away. But you got to get those blood cultures first because obviously with an abnormal neuro exam, I knew I was admitting him and inpatient will want those blood cultures. So this was his MRI. I had suspicion for epidural abscess, obviously, with him, but that's a really long reading. But anyway, what it's basically saying, what it said was he has osteomyelitis of his spine at L2 and L3. He had this weird epidural pocket of pus that the radiologist called me on, but they were not reading it as an abscess yet. So I called neurosurgeon right away, and they were not too concerned. They said there's no abscess, so this is not neurosurgery. And, you know, you can admit the patient, but there's nothing we're going to do about it at this point. And I even had told them that he had an abnormal neuro exam, but they didn't want to do anything about it at that time. So you obviously tell your ER attending at that time, you start IV antibiotics after the blood cultures, and you call neurosurgery. So yeah, this patient, yeah, neurosurgery, did not want to do surgical intervention, but he was admitted to the hospital. He got IV antibiotics. They did do like a biopsy of that pus that they saw in his spine. His cultures showed MRSA and serratia. So, but they didn't see any signs of cord compression. I think he ended up getting discharged with like where he was supposed to be coming once a week for IV antibiotics, and I don't know that he's going to be doing too well with that. So I'm sure I'm going to be seeing him back with a full-on epidural abscess. But so yeah, these are high-risk populations: drug users, homeless, immunocompromised. So HIV patients, you always got to think this, and IV drug users, you always got to think it. Especially, and the problem with this, it's the same patients that are usually coming in for this chronic back pain all the time, but you have to take every patient seriously, and every day is a new day, and you never know what's going on with them. So like I said, this guy had actually been to the ER 2 times in the week that I saw him, and he kind of got blown off because everyone just thinks he wants pain meds, but he really did have something going on with his spine. So it's hard sometimes to not be jaded, but you really have to take every patient seriously and always think the worst and go with your gut. So, but yeah, so epidural abscess, antibiotics, and surgery if it's an actual abscess. This patient didn't have an actual abscess quite yet. Questions on that case? Vancomycin, yeah. So when he got admitted, I want to say he got Vanc, Zosyn, and even Clinda. Like, they kind of loaded him up until his cultures came back. But he got Vanc, and then outpatient, I think he was supposed to be coming once a week for Vanc. I don't know that he's doing that, but that was his plan. So yes, vancomycin. Any other questions? All right. So this case, we have a 20-year-old female presents to the ER with sore throat for 5 days. She was diagnosed with strep throat 3 days earlier in the ER, and she has been taking the antibiotics of amoxicillin, but things are just not getting better. So she had taken 3 days of it, and she was not getting better. She had muffled voice and fevers on her exam. She did have a 101.2 temp, heart rate 88, BP and O2 sat unremarkable. So what are we thinking with her? Yes, and what tests do we want to order on her? So we're thinking peritonsillar abscess. Do we need to do any imaging on these patients, or do we just look, or what do we do? Yep. Open your mouth test. Good. Yep, that's good. That's a good exam. And then, yeah, of course, so we are going to do a CT. A lot of times this can be a clinical diagnosis, but when you call a specialist, they're going to want that CT to see how extensive it is, what exactly is going on. So yeah, on this patient, she had a muffled voice on her exam. Her left tonsil was greater than her right. She had a little bit of a uvula shift, but she didn't have trismus or drooling. She looked sick, but you could tell she was uncomfortable, but it wasn't obviously a peritonsillar. Her left tonsil was greater than right, but you can see that too with strep throat sometimes, so you don't want to miss it. So labs, yeah, we want to do, of course, CBC, CMP. I like to do CRP on these. She was already strep swabbed 3 days prior in the ER, but that I always still do strep swab, and also always think mono. You can have mono and a peritonsillar abscess, but I would just do the mono test too if you're going to get blood. It's a blood test, so just add that onto your labs with her. And then imaging, yeah, is going to be a CT neck with contrast because you're looking for infection. So anytime we're looking for infection, we want that contrast to look at it better. So treatment on her, I called ENT. Usually they're admitted. Actually, I wish I put the CT on this patient, but they actually didn't want to admit her. They said, give her an IV dose of Clinda and steroids in the ED, and we'll see her tomorrow in our office. So, she was eating, drinking, she looked okay. So I did actually send this patient home, but most times you're going to admit this patient and ENT is going to drain it. Sometimes you can drain it in the ER. I remember in my residency, they let me drain one, and it was pretty fun. But it's not something that we usually do. I think the attending just let me do it because I was in the residency, but not usually something you call ENT first and get their advice. So yeah, peritonsillar abscess, most common deep space head or neck infection in children. So the most common cause of it is the group A beta hemolytic strep. The keyword on your boards is hot potato voice. And the difference between this and strep is usually that it's the unilateral findings. IND clindamycin for 7 to 10 days is usually what the ENT is going to tell us. Any questions on peritonsillar? I feel like you guys probably know that by now.
One thing I do want to mention is a lot of times, I'm sure, Maggie, you come across this, right? They want that CT because they want to see if there's any impairment of the airway.
Yes.
There's any impingement. Is that extending? Is that pushing on the airway?
Yes.
So sometimes that will gauge their admission. Sometimes if you can get them to take oral things after IV steroids and your IV antibiotics and fluids and pain medicine, and they're pretty stable and it's not affecting the airway at all, the CTs, whatever, that ENT will say, hey, go home and I'll see me in the office the next day. So but I think that CT does become pretty important to determine the course of treatment for that patient.
Yeah, totally. And because you want to see how extensive it is too, like Stacy said, if it's airway involvement. I think that's the biggest kind of thing. Yeah, I honestly don't feel too comfortable sending these people home, but if the ENT says it and, you know, I know they're going to see them tomorrow, then you just give them real good return precautions and you're usually good with that. All right. So case 9, 60-year-old male presents to the ER with chest pain for 1 week. Pain became more intense a couple hours ago, and now it's radiating to the left arm. I keep messing up male and female, guys, sorry. But she complained of diaphoresis and 2 episodes of vomiting. Vital signs, her BP was a bit elevated. So what are we thinking? What are differential diagnoses on this? MI, good. Acute coronary syndrome, yeah. What else though? What are we thinking? I mean, this patient, obviously we know it's something bad since it's a case, but this is a very common person who comes in the ER, and probably 1 out of 50 times it's actually an MI. GERD, perfect. And then, so some other ones, you know, always, so any chest pain, we think MI, pulmonary embolism, GERD, perfect. Someone said PE, a pneumothorax, perfect, awesome, yep. Dissection, awesome, yep, AAA, yep, all of those. And then of course, you know, you always think it could end up being, yeah, costochondritis or muscular as well, yeah. So this is a very common patient in the ER, and like I said, it's rare that it's really the MI that we see. Yep, good job, guys. Okay, so medical history, hypertension, diabetes, high cholesterol. So they kind of got the trifecta. We always look at those. So that's 3 big old risk factors that this patient has. They take lisinopril, metformin, and atorvastatin for those, drinks, smokes, no drug use. Father had an MI at age 59, mother had no history. And on exam, diaphoretic, distress, but otherwise, I think probably tachycardic, but otherwise normal exam. So this was their EKG. So what do we see on this EKG? I know EKGs are hard. Anyone a guess, or do you just want to talk about it? Wow, you guys are smart. Anterior septal STEMI, yep. Yeah, so we see a STEMI. So with this EKG, yep, heart attack, yeah. So V1 through V3 is the anterior septal. So you can see ST elevation here. And then you see ST depression in 1, 3, and ABL. So 1, 3, and ABL, you see some ST depression. So this tells us it's an anterior STEMI, and that's the most common one. And then, you know, so that's for anterior. Lateral, you would look at 1 ABL, V5, and V6. That would be a lateral. And then inferior is 2, 3, and ABF. So I don't really remember if you need that for boards, but those are just kind of the main ones. So this patient's troponin was 2.3, so that is elevated. Chest x-ray was actually unremarkable, not much to it. So on this patient, we always give aspirin pretty much right away when they complain of chest pain. It's just kind of a given in the ER. The nurses usually even pull that when they get back to the room. But I also gave them nitroglyceride 0.4, and you keep doing it every 3 to 5 minutes. If their pain's not better, nitro can often give them a headache. So sometimes you'll have to add a headache medicine, but you're watching that blood pressure. And on this patient, so we knew it was an MI right away with the EKG. So you call the cath lab, and I'm at Winter Garden, which is a small standalone ER. So these patients get helicoptered out right away. And the goal is to get them to the cath lab within 90 minutes. And we did all of that for this patient, and they found a 99% blockage of the LAD, and they were stented and did just fine with it. So it worked out in their favor. So this is acute coronary syndrome. We could go into this for a super long time, but I'll try to keep it short. So STEMI is obviously when there's an ST elevation on the EKG, they have a positive troponin, they go to the cath lab. That's, you know, your go-to. Non-STEMI, their EKG looks normal when they come in. They're still having this chest pain and everything. When you get their lab stack, their troponin's positive, and you're like, oh no, this is a non-STEMI. You call cardiology, and then the cardiologist will decide, does this patient go to cath lab? You know, are we super concerned? Do they just get admitted for repeat, you know, EKGs? It really depends on the cardiologist and what they think of the patient. And then your unstable angina is when the EKG is normal, the troponin's negative, but they keep having this chest pain. It's really not getting better. So you admit them for observation where they keep doing troponins, EKGs, and just kind of monitor them. So on these patients, what I learned in my residency, these are good things that you need to put in your chart. So do they have exertional chest pain? Are they diaphoretic? Do they have pain radiating to right or both arms? You know, you usually hear like this whole left arm thing, but it's actually, it can go to both arms and it can go to the right arm. And then did they have chest pain with vomiting? If they have any of those things, you really got to have a high suspicion that something else is going, that, you know, acute coronary syndrome is going on with them. So it's always something to think about. And then in the ED, we do something called a heart score, which kind of classifies their risk factors. So it has to do with age, their history, their family history, their risk factors, their EKG, and their troponin. So it's this kind of category that we put in points. If you ever work with me, I'll show you it on my screen. But it just kind of classifies them. So if they're less than 3, it's usually a safe discharge. If they're more than 3, you admit them for observation, where it says here this unstable angina. So these are just some pros for your exams. CK&B is not something I ever order in the ER, and neither is myoglobin, but I remember learning these in PA school, and they killed me because I just could never get them straight. But what you should know is troponin is the #1 cardiac enzyme. That is the one we order in the ER, and it's because it appears 1 to 2 hours. So it's that quick one, and it can remain elevated for actually quite some time. And then the other ones, you guys can just kind of read those hours on your own, but they're good to know. Kussmaul sign is when there's a rise in the JVP, the jugular venous pressure, on inspiration, and that's usually indication of right heart dysfunction or strain. In cardiology, we also, wait, I'm reading your question, maybe frequently. Yeah, so that's good. So any pain with exertion, exactly. So that's kind of what I was saying on that last slide. So any pain with exertion, that's kind of going to cue you in that it could be an MI since it's with exertion, and then with the vomiting or any type of radiation. Yeah, and exactly. So you're good. Anything with exertion, then you kind of are really thinking, yeah, something's going on with this heart. So the STEMI, the most common location is the anterior. So, and that's 40 to 50% of cases. So that was kind of the case that I showed you, and that's the most common. Any questions on that? MI is a big topic. And I know cardiology is a big topic on your guys' exam, but you know, that's kind of the ER standpoint, what we look at. We're pretty straight to the point. Is it an MI or is it a STEMI? Any other questions on that? So this one is a 28-year-old female. She has chest pain for 3 days. She came in today because she has been feeling short of breath with any activity, no fever, abdominal pain, nausea, vomiting, diarrhea, or back pain. Vital signs, a little tachycardic. In O2 stat was a little low, 95%, good. Nick already got it. PE, perfect. So yeah, that's what we're thinking on this young female with shortness of breath. It's always the thought, and pretty much the same differentials that we just went over on the other case. You always think, you know, tension pneumo, spontaneous pneumo on a young person. Is it acid reflux? Is it costochondritis? But this case, you know, obviously we are thinking PE. So what is the big thing you guys see on this slide that even tells us more about PE? Yeah, good job, Andrew. So yeah, so she's on birth control. So that is a risk factor for PE, and we have to think that. I didn't put in if she drank or smoked, but smoking is another one. So, you know, smoking and birth control, a young person with chest pain, you have to think PE. So super important on that. And then her exam, she was tachycardic. So that's another one. She's tachycardic. What for? That's a cue. So what specific tests should we order on her? What is kind of like, what am I looking for here that we order for lab wise? Troponin and D-dimer. Good job, Melissa. So yeah, so we always order D-dimer first on these patients. You know, it's a screening tool. And, you know, it can be elevated for so many different reasons, but if it's elevated, you order that CTA. If it's negative, it's negative. But if it's elevated, you got to look a little bit further. So we usually always start with D-dimer. So this is kind of, I think this might be on your boards. That's why I put it in there. To be honest, in the ED, like I've seen this before, but it's not like when I look at an EKG right away, I'm like, oh, this is a PE on the patient. But it's just something to think about. It's the whole S1Q3 T3. It's something that I learned in the residency to always look for. I can't remember if I learned it in PA school, but basically it's saying that in S1, they have this depression, and then they have Q waves in 3 and inverted T in 3. So that's why it's S1, Q3, T3. I don't know if that will be on your boards, but my ER percentage will be that I can actually see. Yeah, exactly. So it's not something that's like someone hands me an EKG and I'm like, that's a PE, S1, Q3, T3. But it's just something interesting to look for, and that's just boards questions. But yeah, you're not really gonna see it. It's rare. I would say EKG is the main thing you see as an MI, you know, that's what you're looking for. But maybe on these PE cases, if you look back, you could maybe see it once you already know the diagnosis. So yeah, on her troponin was negative, but her D-dimer was elevated. So I ordered a CTA, and she had a pulmonary embolism on the right side with no heart strain. So we admit her, she's on anticoagulation, and that's what you do with these patients. So it really depends, like, is there heart strain, is there no heart strain? That will depend on where they go, whether it's ICU or just a normal admit. This patient, everything else was pretty good on her. Her vitals were okay. So I think I just admitted her. She got anticoagulation, and she was in the hospital a couple days, and she did well. She ended up just staying on probably Eliquis for a couple weeks. So PEs, so it's basically, the definition is a thrombus in any other region of the body that goes to the pulmonary vascular tree. So most commonly, of course, it comes from that DVT. So risk factors, oral contraceptives, smoking, and that's on the young people. And on the boards, this Virchow's triad, trauma to the vessel wall, hypercoagulability, and stasis of blood. So that's also risk factors for the DVT. Physical exam findings, tachycardia, Holman sign, that's when you squeeze the calf, and then you always look for unilateral limb edema, meaning DVT. Did it go to the lungs? Boards, I also could not tell you what this stuff looked like on the x-rays. But Hampton's hump, wedge-shaped infiltrates, and Westermarck sign. I honestly don't look for that on x-rays in the ER, but those are keywords for PE on your boards. And then the gold standard test is pulmonary arteriograph, so CTA. All right. Oh yeah, so this is the PERC score. So if all of these are negative, so PERC score is kind of like, do we order a D-dimer or do we not order a D-dimer? So if all of these are negative, you don't necessarily, or you don't need to order the D-dimer, but you have to have, this PERC score is only used in patients that are less than 50 years old, and it just kind of kind of follows all the risk factors. So do they use hormones? Have they had a DVT, recent surgery, hemoptysis, all of this. So basically, if any of those things are positive, then you order the D-dimer. And that's the PERC score. It's just something to always think about. Any questions on PEs, guys? All right, so case 11, 68-year-old male presents to the ER with tearing chest pain that radiates to the back for an hour. He feels short of breath, he's sweaty and feels fatigued, no fever, chills, nauseous, vomiting, or abdominal pain. His blood pressure was a little low, 100/80. That was the big thing on the vital signs that sticks out. So what are we thinking? Yes, aortic dissection, yeah. So this is a big one to always think about. So he also had a history of high blood pressure, diabetes, and high cholesterol. His exam, he was diaphoretic, he looked sick, he was tachycardic, he had an aortic regurg murmur, and pulses is always important to check on these patients that you're thinking it could be an aortic dissection, because usually their pulses can be weaker in their lower extremities compared to their upper, and that's huge, and you need to document that if you work in the ER, because that's something that is super important to document, that their pulses are equal in bilateral upper and lower extremities. So this was his x-ray. So what do we see here? Good, you guys got it. Good job, guys. So yeah, wide mediastinum on him. So I think the measurement is like, if it's greater than 8 centimeters, they consider it wide, but that's what you always look for. And when you see this, because usually chest x-ray can even be done before labs get back or anything. So if you see this, you're thinking it, you're calling already, you're calling vascular, and you're trying to get that CTA of the chest. So yeah, so we had high suspicion in this patient, goes to CTA right away. You tell your attending, obviously, get them involved, and you call a cardiovascular surgeon and manage their blood pressure, because blood pressure can get really low in these patients. So you might have to put them on pressors, and you just kind of manage them hemodynamically until they're out of there and they get treated. So the aortic dissections are most common in the ascending thoracic aorta. The board questions will say severe tearing, ripping, stabbing pain. And then there is 2 types, A and B. A is proximal, and the person's more likely to have anterior chest pain. B is distal, more likely to have back pain. Again, that's not something we know in the ER, but I remember learning it in residency. Chest x-ray, wide mediastinum, and then you want to make sure if their blood pressure is high, you treat it with beta blockers, but if it's low, if they're already hypotensive, then you treat it the other way. So you're just really managing how they're presenting. Questions on aortic dissection? And usually with these, their chest pain does not respond to medicine. So that's a big one too that could be in the question on the boards, is that they keep having this chest pain that's not responding to anything. You really got to think aortic dissection. All right. So this case, 44-year-old, if they're hypotension, what pressor? It really depends. Usually at that point, you're going to be calling the ICU, and they're going to have them put it on some kind of drip, the patient on some kind of drip. So it depends. I wouldn't want to tell you one and have that be on your mind, because if the boards ask that, I'm not sure what you guys would learn. But the ICU doctor is usually the one that's going to tell you kind of what to put them on to manage it. All right. So 44-year-old female presents to the ED with a headache for 2 days. She said, I remember this patient worked at Disney, and she said, 2 days ago, I was at work and I had this intense episode of dizziness. I had to sit down. She felt like the world was spinning around her. And then after that, she had like this dull headache on her right side, but the dizziness had resolved. And she said she felt like she was kind of like drunk walking. That's how she described it to me. But she had no other neuro complaints, numbness, tingling, no weakness, no change in speech or vision. And like I said, she had come in 2 days after this episode had happened. Vitals were okay. Oh, no, that's okay, David. MRI angiogram is the gold standard. Yeah. So that does not happen in the ER ever. Like, I have never ordered an MRI angiogram. Yeah, never. I mean, at the most, you're going to get this patient to CT and then you're going to find it. It's not, that's gold standard for boards, but I want to know how many of those have ever been ordered in life. So no, definitely not in the ER, but on your tests, that should be, yeah. Okay. So yeah, this patient said she felt unsteady walking, but no other neuro complaints. Vital signs were stable. She had history of high blood pressure, diabetes, high cholesterol. On her exam, she had some photophobia. She was almost presenting like a migraine headache. She had like sunglasses on in the room. Light was really bothering her. And then her neuro exam was completely normal until I made her get up and walk, which is super important. If you work in the ER, you gotta see them walk. If they walk in the door, that's fine. You don't have to get them up when they're in the room, but if you got to get them up to walk. So when she got up to walk, she was walking like she was drunk. Something was unsteady about it. It wasn't like she was falling to one side, but she was definitely unsteady on her feet. So what labs, what imaging? So it's just going to be your basic labs again on this patient, and then imaging. CT without contrast is pretty much the go-to. Yeah, good. So this was her reading, which was weird. You guys can read over that, but essentially she just had an abnormal head CT, and it was an acute to subacute PICA infarct. So PICA is posterior inferior cerebral artery infarct. So kind of rare, and that's what the radiologist called me and told me that, and I was expecting something to be off, but I wasn't really expecting that. So anyway, she got admitted. They did full MRI and MRA of her head, neck, and brain. They ended up finding stenosis of her carotid artery, and there had been like thrombosis of the right vertebral artery. So that must have been what kind of got off and went on to cause that infarct in her PICA region. So upon admission, neuro and vascular surgery were consulted, but she wasn't a candidate for surgery because it had been so many days. But her neuro exam continued to remain normal while she was admitted. So I kind of was treating her like admitted her for a TIA essentially, and I knew that they would do the rest of these tests because by now it's already been 2 days. It's not like you're treating this as an acute stroke because she had waited 2 days to come in. So, you know, and again, she presented kind of like vertigo. So this is just, you guys could read over this. I don't want to, I feel bad because I thought this was only going to be like an hour long, and it's long, but peripheral versus central, what percent of stenosis? So it doesn't, stenosis of the carotid, it's more so, depends on the patient, but they may put a stent in her carotid artery. So that's the one in your neck. So as far as surgery, like neurological surgery on this patient, it would be rare that they would do that. They're usually just going to let this small infarct resolve on its own. If it's like an acute CVA, then that's when they're going to go in and do surgery. But I don't know the exact percentage of stenosis that they do, but they didn't even stent her carotid, and she had 75%. So I feel like it has to be almost 90. So peripheral versus central vertigo. You guys can just read over this, but essentially central is the bad one. That's usually when you're going to find neurological symptoms, double vision, ataxia. And as you can see here, these are the causes. So these are the bad, scary ones. You don't want to miss them. Peripheral is more like your everyday vertigo. Meniere's is a very likely cause of it. And they don't have neurological symptoms, but it's really, vertigo is very hard, you know, because these people can really throw you off. You can think this is just Meniere's, this is no big deal, but it, you know, you don't want to miss a TIA or something like that. So you always got to think through these, but vertigo is a tricky one in the ER, I find it to be. Oh, good, 70 to 99%. Yeah. I don't know. I think it will probably depend on the admitting doctor that will see them. Because like I said, she was 75% and they didn't send her or do any surgery. So it's interesting. I think it will probably depend case by case and the doctor who sees them. So again, stroke, this is like a huge topic, but I just tried to like put some keywords into charts for you guys because that's how I always like to learn in PA school, just like the main things. So you guys can kind of read over these on your own, but essentially there's different types of stroke: hemorrhagic versus ischemic. Under hemorrhagic, we have the intracranial hemorrhage and we have the subarachnoid hemorrhage. So subarachnoid hemorrhage is what you would see as worst headache of my life. It's usually a younger person. You can see this a lot of times it could be someone who had just exercised or had intercourse and they had this worst headache of their life and they come to the ER. And the most common cause of that is the rupture of the berry aneurysm. And then you have your intracranial, that's usually due to like hypertension or something like that. And then as far as ischemic, there's those three different types: thrombotic, embolic, and lacunar. Thrombotic's the most common. That's kind of what you guys hear about with stroke: left-sided weakness, change in speech, all of that. That's your wake up with these symptoms. And then embolic, the middle cerebral artery is the most common, and it's usually abrupt, but then they start getting a little better. So that one's kind of tricky sometimes because it could be an older patient with like dementia and their family said, they were acting weird, but then they started to get better. So it may throw you off a little bit to not think stroke, but you always got to. And then, like I said, TIA. So that case that we just had, I was really thinking TIA on her, and that's essentially like a mini stroke. It's usually acute symptoms, then they resolve completely within 24 hours. But you got to be careful with these patients because they're more at risk to have a stroke, in the next couple months. So you can think vertigo on them, but you got to be careful. You always got to think TIA on these patients because their symptoms resolve completely sometimes by the time you see them. So you just got to take their word for it and trust that they had those symptoms. Any question on stroke? That's a huge topic. We could go into that forever. So I think I just tried to hit the main points of it. All right. So this is a 38-year-old female. She's G2P1, which means she's had 2 pregnancies. Well, this is her 2nd pregnancy, and she has 1 healthy baby. She presents to the ED with abdominal pain since this morning. She's estimating herself to be 8 weeks from her last menstrual period, but she has not seen an OB yet for her pregnancy. She complains of vomiting and some spotting this morning. So what are we thinking? Yep, ectopic, you guys got it. Yep, threatened abortion, ectopic. Yep, so we know something's kind of going on with her pregnancy usually. Not always. You can have some spotting early in pregnancy, but you got to think something's off. We got to do kind of a full workup on this patient. So she does have a history of smoking, but she had a healthy first pregnancy. On her exam, her pelvic, she had left adnexal tenderness. So what do we want? What labs and imaging should we order on this patient? HCG quant, yeah, so definitely quant, and that's the one where you get the actual number. And yes, pelvic ultrasound. What about, there's something else that we want to order on her? Definitely we want to do a pelvic exam. Yeah, so they usually do a transvaginal ultrasound if they're less than 14 weeks. So yeah, coags, yeah. RH. So Kyle, that's what I was looking for is RH. So anytime a pregnant person has any spotting or bleeding, you always want to order RH. And we'll talk about that. But yeah, good job, guys. So on her qualitative pregnancy was positive. So that's just a positive or a negative on qualitative. And then her quantitative was over 4,000. And then her blood type was RH-O positive. Okay, and then this is her ultrasound. You can see she has this left adnexal mass and she has no IUP. So that is concerning right there because this quant is way too high to see nothing in the uterus. And then, like Kyle said, you want to order RH. And the main reason for this, so if she was RH negative, we need to give her something called RhoGAM. Anytime the woman is having bleeding and they're negative, they got to get RhoGAM. So always important to order a full blood panel on these pregnant patients, because if they do need to go to surgery quickly or anything, you need coags, you need their blood type all ready. So just send it all at the beginning. So yeah, this patient, so this was an ectopic pregnancy because she had nothing in her uterus and she had a mass in her adnexa. So we called OB-GYN right away. They took her to surgery, unfortunately, and you know, they had to get rid of the ectopic pregnancy, and she lost the pregnancy. But that is something you do not want to miss, as an ectopic pregnancy. So this is just a little bit of info on them. So ectopic is just any pregnancy that's not in the uterus. It could be anywhere, but the most common place you're going to see it is in the fallopian tube. And they're at risk if they smoke, and that patient did smoke, so that was her risk factor. Increased age, she was 38. That is, I mean, people say it's increased age for pregnancy. It's getting less that way nowadays, but she's considered, and over 35, they consider that increased age if she's had a previous ectopic or a prior tubal ligation. So even if a patient tells you they got their tubes tied, you still need to be doing pregnancy tests on these people, because they can have an ectopic pregnancy. So if they have the parts, you got to do a pregnancy test. If they had a full hysterectomy, obviously you don't have to, but if they have the parts and they just had their tubes tied, I've seen it. People have been pregnant and they have a tubal pregnancy, so don't miss that. Basically with these, the way you're looking at it is if their quant is less than 1500, it can be early. It could be an ectopic, or it could be a spontaneous abortion on this female who is bleeding. It's hard to say. Less than 15,000 or 1500, we don't necessarily see anything in the uterus yet. So it's hard to say. We got to keep watching it. If it's greater than 15 and there's nothing in that uterus, it's an ectopic or a spontaneous abortion, and you can't miss it. So again, it's not always clearly seen on the ultrasound. So you don't always see this mass in the adnexa. Sometimes, I mean, the definitive is when there's that fetal heartbeat or pull outside of the uterus. That's when it's obvious, and that's great for you because it's obvious, you know what it is. But sometimes they'll read it as just an adnexal, it looks like an ovarian cyst or a mass, but you know, it's hard to say if they're super early on in pregnancy, so they got to get close follow-up. And then of course, indeterminate is when there's the empty uterus, and there could be a gestational sac inside the uterus though, but that doesn't necessarily mean it's not an ectopic. You just got to keep monitoring these patients. So a big thing that's probably going to be on your boards is that the yolk sac is the earliest finding confirming the intrauterine pregnancy. So that's kind of the first thing you'll see on these patients. And she was 8 weeks and her quant was 4,000. So we definitely should have seen something and we didn't. So we knew something was wrong. And then again, if she was Rh negative, you would want to give RhoGAM. So that's important. Any questions on ectopic pregnancies? All right, trying to go faster, sorry. Okay, so 55, I think this might be the last one actually, case, and then there's just some other stuff. So 55-year-old male presents to the ED with cough and fever for 4 days. He's been feeling tired and he's coughing so much he can't sleep. No chest pain, no shortness of breath. He's not complaining of anything else. Low grade temp, but otherwise vital signs look fine. No social history, no medical history. On his exam, he had coarse breath sounds, but when he would cough, it would clear, like it was more mucusy, but his heart sounded fine. So, you know, we order, not necessarily always order labs on this patient. Sometimes you could just start with an x-ray, and if you see what we're looking for, then you could add some labs. But on him, this was his x-ray. So here, we see, what do we see? Anyone see anything? Yeah, good job, Kyle. So we definitely see right lower lobe and almost even up here to the right middle lobe. So he definitely had pneumonia, right-sided pneumonia. His labs were unremarkable though. He was younger, healthy, no history. So we could send him home with outpatient antibiotics. So what do we want to do for community acquired pneumonia outpatient? Yeah, azithro, yeah. I would always say azithro. So just a Z-Pak. Doxy could be if it's more of like immunocompromised person or if they're allergic. So yeah, azithro is probably the go-to. So most of these patients, you know, if they're young and healthy and they look and feel okay, they can go home with azithromycin. Always, you know, have them come back for a recheck and give them strict return precautions. Usually, I mean, you admit people if they failed outpatient, if you have concern for hospital acquired, if they're from a nursing home, if they're immunocompromised, or if their vitals are not stable. And then you think about the CURB score. I don't remember if I learned that in PA school or the residency, but the CURB score, it's when they have to be less than 65 years old, and then it has to do with confusion, their BUN, their respiratory rate, and their blood pressure. So C is for confusion, you'd have to write it out, but it says BUN, that's what the U stands for, R is respiratory rate, and B is blood pressure. So you look at those things and it's kind of like a risk stratification score for how sick they are, and it predicts like their risk within 30 days of them getting even sicker. So this again, the rest of these slides kind of go into, I think, charts that I would find helpful as a student. So I just wanted to do that for you guys, but just kind of goes over the main things. There's a lot more to pneumonia, obviously, but these are just some main points. So community acquired, most common is strep pneumo, and that's classically a productive cough with rust-colored sputum. You're usually not going to hear the patient say that, but that's boards. They usually have infiltrates on their x-ray, and you treat them with azithro. And then the hospital acquired is, of course, if they've recently been in the hospital, and most common is staph, ICU. You always got to think Pseudomonas because of their respiratory. So you got to think that on those patients. So these, I just remember these being hard in school, so I put them up, but it's just kind of main points. So your questions might ask something like this, and then you can just remember these buzzwords and get the answer right. So you guys can look over those on your own. Any questions about those? All right. So these slides are, again, just something for you guys to be able to look over on your own pretty much. I don't need to like read word for word. I know that's annoying, but we can just kind of flip through them. Oh, so this, I don't know if you guys learned this, but murmurs were always super hard for me. And it's probably going to be hard for me to explain this without drawing it, but it's just an easy way to remember systolic and diastolic murmurs. And I found it really helpful because that alone can eliminate so many answers on the boards. So for systolic murmurs, did you guys learn this in school at all? Okay, cool. So you guys probably already know it. So I just Mr. Taps, and you separate Mr. Taps here, mitral regurg, tricuspid regurg, aortic stenosis, pulmonary stenosis. So it's just an easy way. Like when I took my boards, I wrote this out right away because cardiology is such a big part of it. And this is just a simple way to know those diastolic and systolic. But if you guys already learned it, then I don't need to go through it. But this is just kind of breaks it down, and it can give you those answers pretty quickly. Any questions on it? So this is just some pulmonary stuff, common viruses that we see in the ER, definitely, that you always want to remember. Bronchitis, mostly rhinovirus. Their x-ray is usually normal. They usually don't need antibiotics. Bronchiolitis, you see it in young kiddos, usually like during flu season. They present kind of sick sometimes. They can have nasal flaring and wheezing. And RSV is their most common virus there. Epiglottitis, this is usually a kid that's kind of hunched over in bed, drooling with stridor. It's that classic thumbprint sign on the x-ray. and H. influenza is the most common. And then you have croup, which is your barking cough and your steeple sign, and pertussis, which is your whooping cough. I just, you know, hopefully this chart will help you guys. I don't need to read it all. Oh yeah, sure. I can go over the murmur chart. I thought I was boring you guys because I thought you already learned it. So the murmur chart, so again, so Mr. Taps is systolic. And basically right here, you just write out Mr. Taps, but you split it down the middle. And then this, so from MRT, you get MR and TR, because those are the two types of murmurs. So mitral regurg and tricuspid regurg. And those are always related to S1. So a lot of times on your board questions, you know, they'll say something about S1, and that can kind of help eliminate a lot for you guys, because it's going to be usually mitral regurg or tricuspid regurg. And you hear it at the apex of the heart the best. So again, if your board question says something about the apex, it can kind of help you eliminate those other ones. And these murmurs here are best heard with the bell of the stethoscope. And then the other part of Mr. Taps is APS. So again, these APS would break down to aortic stenosis and pulmonary stenosis. They're more S2 murmurs that you would hear. They best heard with the diaphragm and at the base of the heart. So like I said, I just kind of memorized this chart for my boards, and you would be surprised, because when your brain is so sick of reading all those questions, it's an easy way to just like go to this chart and say, okay, we know it's a systolic murmur, we know it's mitral regurg, and you can kind of go from there. And I drew the arrows up this way because all systolic murmurs radiate up. So that can be another thing on the exam. It may say, you know, it radiates from the apex up into the person's axilla, and that can tell you that it's a systolic murmur. And then basically the opposite, these right here, you just literally do the opposite. AS, the opposite is AR, PS, the opposite is PR, MR, the opposite is MS, TR, the opposite is TS. So these murmurs, aortic regurg, which is going to be your Austin Flint, that's kind of like the keyword on that. Pulmonary regurg, mitral stenosis, that's your opening snap murmur, and then tricuspid stenosis. So I don't know if that makes sense. It would help me if I could draw it for you guys and tell you how to do it. But basically, if you remember this chart, you're going to be able to eliminate a lot of answers on your boards. And I found it really helpful. You can look it up on YouTube. Just type in like Mr. Taps murmur, and there's this guy that kind of goes over it and tells you how to draw this chart, and it's really helpful. So he probably explains it better than me because he'll draw it out with you. Does that help at all? Sorry, it's kind of hard to explain just looking at it. Okay. So asthma, super important to learn for the boards, but I'm not going to read all of this, but I would just really know that it's an IgE response. You have the atopic triad of asthma, eczema, and seasonal rhinitis. And then these stages. This is not something that I know in the ER at all. You know, we just see a patient with asthma and we treat it. But for your boards, you're going to want to kind of know this, because they may say something like this as far as treatment goes in your question. So basically mild is when they're having these brief symptoms, but it's not every single day. Mild persistent, they're having greater than 2 a week. And then moderate persistence, the different here is that they're having it nightly, at least once a week. And then severe is always just continuous all the time at night, but that's important to kind of break down those stages. So COPD, this is just another chart. I feel like you guys probably know this by now since you're almost done. But bronchitis, so COPD, 2 different kind of categories, chronic bronchitis and the emphysema. You know, you guys can look over this, but chronic bronchitis, it's those blue bloaters. They have a productive cough. They're usually obese, and usually they're presenting that they've had these symptoms for months. And it's just this chronic bronchitis. It's usually not treated with antibiotics. And then emphysema is usually your smokers. They're known as the pink puffers. They've got the pursed lips and they're short of breath. And that's basically when they have like enlarged air spaces distally, and it destroys their alveolar walls. So those are kind of the skinnier patients, smokers, and you see them and you see COPD. Bronchitis, you don't as much always see it as like a COPD patient. Gallbladder, I added this because I should have done a case on it, because gallbladder is super important, and sometimes I know it can get confusing. So the way I break gallbladder down is step one, cholelithiasis, is just when there's gallstones. That's it, there's gallstones. Most common stones are cholesterol stones. Cholecystitis is when we start worrying in the ER. So that's when there's actually an infection there, okay? There's an infection in the stones. And the most common cause of cholecystitis is gallstones, cholelithiasis. So that's where it can kind of get confusing. But usually these patients have this severe right upper quadrant pain. It radiates to their back. They have that positive Murphy sign, which is when you have them take a deep breath, you press on their right upper quadrant and they elicit pain. And then you always want to get that right upper quadrant ultrasound on them in the ED. And most times once they're admitted, they might get a HIDA scan. We don't order that in the ED though. And then you have choleduolithiasis. That's when the stones are in the common bile duct and they can get infected. So again, these patients will get admitted. They'll usually get an ERCP test, and you know they'll likely get that stone removed from the duct. And then cholangitis is like the most worrisome thing. These patients are sick. They have right upper quadrant pain, jaundice, and fevers. That's called Charcot's triad. That's probably could be something on the boards. And then Raynaud's pentad is when they have those three other things, plus they're in septic shock, they have change in mental status. That's more boards again. ER, not something we always, you know, it doesn't fit these categories perfectly, but essentially if it's anything more than gallstones, you're admitting the patient, and surgery will take it from there, whether they take the gallbladder out or not. Questions on gallbladder? All right, hepatitis. This is, you guys can totally just read this chart on your own. I'm not going to read it, but I always found that kind of hard to learn. So you differentiate cholecystitis. No, usually even an ultrasound would tell you. Usually it has to do with labs as well. So you always get an ultrasound on those patients, and ultrasound is pretty good to diagnose cholecystitis. Cholangitis is more so, you know, you're going to see more changes in their clinical presentation. So in their labs, you're going to see leukocytosis, you're going to see elevated hepatic enzymes, and the patient's going to look sick. Their vitals are going to be affected. They look sick. And sometimes the ultrasound can kind of pick up on it, because they'll see like stranding of the duct and everything. So they'll read it as more, the ultrasound radiologist will read it as more than just cholecystitis, basically. So sometimes they'll differentiate it from you, but a lot of times it's clinical presentation. So yeah, this hepatitis chart, I'll just let you guys read over it. I just broke it down because I remembered it being hard, but main thing with this, I would say, is hepatitis B is what you think of with us who work in healthcare. You know, you got to get that Hep B vaccine, so it's an easy way to remember it. Usually your board question is going to say it's a healthcare worker that was at risk. And then hepatitis C is actually really picking up in our community right now with the homeless population and IV drug users. So it's something we've actually been starting to do these vaccines in the ER if they have risk factors. So that one, IV drug users. But yeah, just kind of read over this chart your guys self. But I just thought it was just keywords to kind of break it down. There's a whole lot more to it, but I tried to just do key things for your boards. Glaucoma, just something that I also couldn't remember a case on exactly, but it's something you want to think about in the ER. If they come in with like the severe onset unilateral eye pain, you always got to think of acute angle closure glaucoma, because that is a medical emergency. You got to call ophthalmology right away. They usually tell you to get them started on, they give you like a list of 4 different eye drops to help reduce their pressure. And it's an emergency. So it's the most common cause of irreversible blindness. And on their exam, they usually have a mid-dilated, non-reactive pupil. So if you see that on your exam, that's That's your acute angle. And then your chronic open angle is more so the ones that, you know, your parents or your grandparents have. It's been happening over time and they start losing their peripheral vision. They have tunnel vision. So this is where we'll wrap up. I'm so sorry it was actually 2 hours. I didn't think it would be. But here's some x-rays. So we have a clavicular fracture here. This is super common in the ER, super common in kids. You always want to make sure to take their entire top off and examine them, because you can often see the deformity on your exam, and it can be a pretty clinical diagnosis. You obviously have to get the x-ray, but you'll see skin tinting on their exam. And a lot of times they can be complaining of shoulder pain or elbow pain. The little kiddos don't always complain of right where it is. So it's important to do a full arm exam when they're complaining of pain. But the middle third, this x-ray shows the middle third, that is the most common location. And even though it looks terrible and the bone's completely split in half, these patients usually just go home in a sling and it heals on its own. And then of course the complication with it is the subclavian artery involvement. But that's pretty rare. I would say 90% of these kids I see with clavicle fractures, they just go home with a sling and it heals on its own. I was always shocked the first time I saw that, because I couldn't believe that the bone would just heal itself on its own. This is shoulder fractures. So the biggest thing with this, and for your boards, you can have the humeral shaft fracture, which is this one, obviously right here all the way through. And you worry about the radial nerve injury. So with radial nerve injuries, you're going to see that wrist drop. They can't extend their wrist. They're going to have the wrist drop. And then the proximal humeral fracture, you can see right through here. This one's kind of through the head. And you worry about the axillary nerve being involved. And a complication of that is that they can have avascular necrosis of their humeral head since the fracture is up. And you'll see that a lot in to see, is it dislocated or is it fractured? And usually on their exam, they're going to have more of like the shoulder depression on the, like one shoulder will be a lot lower. You can kind of see that on your exam. All right. Oops. So these are super common, really common. Every day I see one of these in the ER. Your Cole's fracture is the most common distal wrist injury, and that's when there's dorsal displacement and shortening. So that's your Fuchs injury, super common, will be a board question. And then you have your Smith's fracture, which is your distal radius with the volar displacement. So I put that picture there to kind of show you guys. And on these patients, you're going to do the sugar tongue splint. Tibia, so here you have this shows the tibia fracture right through here and the fibula. So in this patient, we would do a posterior, like short leg splint. If it was just the fibula, those are actually usually just, you know, they can still wait there and it's usually non-surgical. But this one looks like it probably would have been posterior splint and follow up with podiatry. Tibial plateau fracture. Usually they present with a lot of pain and they have a large knee effusion and ecchymosis. You're like, oh, I could tell something's going on with that knee. And then once you get the x-ray, it's not always this obvious. You can see it right here, but this is a pretty obvious x-ray. Sometimes you'll just see like the tiniest little hairline right here along the tibial plateau. So it's something that's sometimes hard to pick up on, but you don't want to miss it. This patient would, you'd call ortho and you'd send them home with a knee immobilizer. And this is just some categories of different types and the severity, what they get. Rib fractures, a lot of times they're hard to see. I still have a hard time with these, honestly, a lot. Sometimes I overread the x-rays because I'm looking so hard for it, but it's hard to see. These, I kind of chose obvious x-rays, but it's not always obvious. So this one, you can see it's the, let's see, 1, 2, 3, 4, 5, 6, 4th through 7th ribs right here. And then this one, you can see it right here. 1, 2, 3, so 4, 5, and 6. So with rib fractures in the ER, usually if it's less than like 2, the patient does fine. If they're non-displaced, there's no pneumo, they go home. I usually send them home with like an incentive spirometry machine and tell them to take deep breaths so that this doesn't develop into a pneumonia. Usually if it's greater than 3 fractures, I end up doing a CT scan personally, because you'll often find on the CT scan, there's actually more than 3 and they weren't picked up on the x-ray. And sometimes they'll have like a little pleural effusion there. So anytime there's more than 3, I always do a CT. That's personal preference. I don't know that everyone does that. And then if they're an elderly person with more than 3, I always admit them, because, you know, these people can end up getting pretty sick and get pneumonia. So it just goes patient by patient case on those. I think this is the last slide, and this is just hip fracture. So you can see on this x-ray right through here, through the neck. I think this one would probably be this one, the Garden 3 category. But right through the neck, this patient would have shortening and external rotation of the lower extremity. So that's usually the presentation. They have pretty severe pain in their hips, sometimes down to their groin. And yeah, this is a pretty obvious x-ray, but sometimes in these elderly patients, it isn't always as obvious with these hip fractures. So yeah, and I think that that's it. Do you guys have any questions?
Thank you guys for participating and being here. And Maggie, thanks for doing a fabulous job. That was really great. I mean, I feel like I just did an ER shift. It's pretty much.
I hope so. I just hope it's helpful for you guys. If you have any feedback, please let me know, because I would love to do it again.
Oh yeah.
Someone asked a question.
Yeah, I just want to echo what Stacy said and say thank you very much. This is, you know, exactly what I was looking for in this kind of lecture. So, you know, perfect. Thank you very much. And
thank you guys.
I would absolutely love to have you back when the opportunity presents itself. So.
Yeah, for sure. I would love to do it anytime. So I appreciate you guys asking me. It was fun.
Great.
I hope it wasn't too boring.
Hey Maggie, there's a question about dog bites. What's your take on primary versus secondary intention on dog bites? Do you mean suture repair and no suture repair? iPhone, whoever iPhone is.
If that's what you mean, I would say from the ER standpoint, personally, so it really depends on the dog bite. So if it's super extensive and they have a deep laceration, then I will irrigate it so much, and I will pop a few stitches in it just to bring their skin together. But I usually do them pretty loose, you know, because they're always high risk for infection. And then of course you're going to be sending them home with antibiotics, Augmentin usually. But if it's just a dog bite to where there's just puncture wounds, I just irrigate it out really well, and not usually close. But you know, that's clinically based. I don't really know what you guys are learning, but yeah, I mean, if it's a huge laceration, you can't really send the patient home with that. So I usually will put a few stitches in, and those always say 24 to 48 hour recheck. Keep a really close eye on them, because they are very high risk, especially if it's in the hands.
Right. So face, usually we sew all the time.
Yeah.
That's exactly right. If it's really big and gaping, we throw a few in. That's exactly kind of, it's like a clinical thing, case by case.
Yeah.
No, you ideally don't ever want to sew any kind of infected wound, which you kind of, a cat and dog bite are considered like infected wound. They're high risk wounds. But on the face, it's very vascular, it heals pretty well, but still always antibiotics. Yeah, it is different with every provider.
It's so provider different, and I try my best to not close them. But if it's huge, you have to, and if it's on their face, you know that you're gonna. It's tough, because you usually want to help with their cosmetic. Right. You know, they don't want this big gash, but it's provider preference really.
Anything else? Anybody else?
Anything else, guys? I put my number in my email at the beginning. On the first slide, so please reach out to me if you guys have any questions. I know you're almost done, and that's so exciting, and if you guys need anything, I would love to help. I hope I still get to work with some of you.
Okay, looking good.
All right, guys.
Is there anything else you need? Could probably stop the recording.